Well, thank you very much for the invitation to present today. These are the many individuals who participated in the collection and much of the rest of the research that we did here. I want to dedicate this to Crystal Wiley, who is my long-term helper and ran the clinic. She passed away during the study, and also Ron DeVere, who is a neurologist who had collected a lot of data. Unfortunately, the follow-up data we connected from his organization after his death, so we lost a lot of data, but he was one of the few neurologists out there really excited about this sort of thing. So olfactory training, as many of you have learned in the presentation last evening by Dr. Hummel, is that smell loss reportedly benefits from briefly smelling 4 to 6 odors twice a day for several months. There's lots of studies that suggest this, like physical, like physiological imaging. There's been the argument that those regenerate within the olfactory epithelium, as well as some replacement in central structures. There are limitations, however, to the available olfactory training studies. Most like double blinding, all have a high dropout rates, do not randomly assign contemporaneous controls to account for expectation, practice effects, regression mean, and spontaneous improvement. And when present, controls are usually receive no treatment rather than sham treatment, introducing expectancy biases. Also, very importantly, the control groups are always much smaller, typically much smaller than the olfactory training group sizes. For example, in a study of 8 published olfactory training studies, the cumulative total of patients in the olfactory training groups was 548 compared to 58 in the control groups. So we aren't seeing properly controlled studies in the majority of cases. In that same study, the average training duration of the olfactory training group was 30.6 weeks compared to 23 weeks for the control. So this whole literature, unfortunately, has a number of limitations like that. And when you look at for spontaneous improvement, you'll see that it's very common. That is that numerous studies, there's some samples that show that without a defined intervention over time, there's tremendous improvement in studies that have been done in the past. And some literature, the paper that this talk is based on will be coming out soon. It's going back for some revisions. Only 3 prior olfactory training studies did double-blind randomized controls. None of these found significant effects. For example, here's one, and you can see the bar, the differences between the placebos. If anything, there's a little more improvement than the placebo in this case. Another study, same thing. There was no real difference between controls and the olfactory training groups. And then the final study was based on a larger sample, and as you can see here, that the recovery was actually lower in those assigned to the olfactory training group than those assigned to the placebo group. And many of the meta-analyses of this literature do suggest that, in general, the studies are poorly performed. So we did a 4-month-long daily training period in our training study. We called it sniff training to avoid, so we have a group just sniffing things, and so they don't show it to their neighbor or to the partner and say, oh, hey, there's no smell here, quit doing this. So we don't, and we also chose people that didn't know anything about or reported that knew nothing about olfactory training as such. We had 3 groups. Blank wands, these are this, they contain odors, I did that a little bit. Labeled odorant wands and then unlabeled odorant wands. We also collected some threshold data, but not presented at the time. And they were given 10 odors to smell over this time period, or blanks, and they were investigators and participants were totally blind to the exposure groups. And before and after training, the main test that was given, many of you know about this, is the upset. I won't get into the details of that. The training stimulator presented in its snap and set training devices. The logs that present odors are usually the sliding mechanism. And the final study group, we had a number of non-completers, including some of those that could not get data from Dr. DeVue's lab. But the final study group was, had a sample size of 70, and their dysfunction was due to a variety of different issues here, as so listed. Results, we found that independent of exposure group, 64% of participants had a pre-post training increase in AChemS scores. 26 those were clinically meaningful. But again, there was no difference between the three groups experimental groups. The AChemS scores significantly increased over this time period. The point again, no difference between the three groups. The largest dose increases occurred for the post-viral infection group. And this shows that where we did see in the post-viral infection a 9% change in AChemS scores, and also in aging we saw 7%, and then in the idiopathy, unknown causes is about 6%. Traumatic brain injury, we didn't see much benefit. So this study has both strengths and weaknesses. Again, it's one of the few studies that was double-blinded. We call it a sniff training study to increase compliance with the black odor. Using self-administered tests actually sort of is blind in themselves. So the investigator isn't impacting the performance of the subject. We had the three groups, and then we used 10 training ovens. Now, in retrospect, it would have been nice if we had a group that didn't just sniff as the control, but had just blank, because sniffing alone, there's some evidence that might actually have some effects on olfaction. So that was something that we didn't really think about at the time. Not all subjects received nasal endoscopies, so although that's not a major issue because of the longitudinal nature and so on, but again, it would be nice to have that. The sample sizes in the subgroups are not large, and etiologic categories are not definitive. For example, say through age, what does that really mean? So we don't really know necessarily causation of the losses. So the conclusions, like the three other double-blind placebo-controlled studies we found in olfactory training with the blank was just as effective as olfactory training with odorants. It's unknown whether airflow alone during sniffing can produce the observed effects. The findings do suggest that more well-designed double-blind studies of appropriate sign contemporaneous non-odor trained controls are needed to definitively establish the effects of olfactory training on olfactory function. So I want to thank you for your attention, and I will smell you around.